My name is Kate Erickson, and I'm the Integrated Care Program Manager.
My name is Nastaha Muhammad, and I'm a Psych Care Manager.
And I am Elizabeth Eggers, and I'm a Psychiatric Clinical Nurse Specialist in Adult Psychiatry, and also the Psychiatry Director at Community University Healthcare Center, which a lot of people also call CUHCC, C-U-H-C-C.
So we have full spectrum medical services, preventative care, OBGYN, pregnancy testing, family planning, and pharmacy consultation services. We have dental health services, preventative as well as restorative services. We have domestic violence and sexual assault advocacy. We have a wonderful, 21-year relationship with the legal firm Stinson Leonard Street, and they provide free legal services for our patients. And then we have a wide spectrum of mental health services. So we have ARMS, Adult Rehabilitative Mental Health Services, which focuses on skill building. We have case management, which focuses on stabilization and coordination of services. We're the only clinic in the state that has case management on site, which is really nice for integration of services. And then we have child and adult psychiatry and therapy. We also offer care coordination services and have staff that focus on different specialty areas for any patient who doesn't fit into those other mental health services. We serve around 11,000 people a year at CUHCC, and we're just down the street on Franklin and Bloomington. So if anyone wants to come for a visit anytime, you're welcome to do so. I have my business cards up here. You could contact me directly if you want to come by. The next thing that we're going to do is Elizabeth is going to talk about community mental health programs as a whole. Thanks.
Yes, I am, and I have like a slight something in my throat, so I'm going to try and not cough, do anything funny. Let's see. I'm coming from the conference at the university today, which is why I have this weird name tag. Let's see. Let's take it off and put this here. And I was telling the ladies on my way here that I found some of the conference topics were very clinical and very specific to psychiatry, which about 10% of that room needed to hear. So I'm hoping that we'll offer you some practical ideas on mental health versus mental illness, what that means, and then touch on treatment and resources. 20 minutes to do all of this, not enough time, obviously. So I'm going to hit some high points, and it's research based on what I've learned in my life and my research and my work, and the work with these two lovely ladies and many of the people that I work with at CUHCC and within the community. So you're not going to see a lot of references or, an APA-style documented bibliography at the end, but I think it'll still be good information. So let's go with it. I'm just going to hold this. Does that work? Like a microphone? All right. So mental health, mental illness, and treatment resources. So just a little bit about me. So I put all those letters after my name because I think the mental health world is very confusing. There's a lot of things that go after people's names in healthcare in general, and no one knows what they mean. So for me, I have my Bachelor of Arts from St. Olaf. Went to school with somebody in this room who's now an excellent contact in the community for me, Kara Miller, famous right there. I also have my Master's of Science from the University of Minnesota in nursing, specifically psychiatric nursing. So that was how many years of schooling? That was 7 years of schooling, so that I am now able to prescribe medicine, but only after I took my certification to be a registered nurse, and then also took another licensing exam to be a clinical nurse specialist, kind of like a nurse practitioner. So it's goofy, and there's a lot of us out there that are practicing and prescribing, but not a lot of people know that nurses can prescribe. So you may see NP, CNS. Now there's a DNP, and I'll go over that later, that people have after their names. So there are nurses that can prescribe psychiatric medication and other medications working in the world. And some of them happen to get to do things like direct programs and be in charge of psychiatrists and do all kinds of fun things. So that's a little bit about me. Next slide, please. We like to talk on my team about mental health versus illness, and I think everyone has mental health, and most people at some point have experienced some sort of imbalance that makes them feel a little ill, right? So stress, anxiety, moving, work changes, family life changes, having a baby, divorce, marriage, all those things can kind of throw us off balance. So I like to say mental health is when you're like this guy and you're on your fingertips holding up your whole body in the world and feeling really awesome. And then sometimes we kind of stumble and we're going along fine, and then all of a sudden, boom, something is not working quite right and we fall on our faces. And that's, I think, the story of a lot of our patients. Things are just barely hanging on, and then some hitch comes up and they fall on their face. So what can we do as people working in the community to support that and make sure that all folks kind of know what their supports are, so that when they start to tumble, they don't have to fall all the way on their face. They can maybe scrape their knee or maybe break a bone, but at least they don't totally gash their head open, right? So that's kind of the pictures that you can have. So mental health is balance. Illness is when things get out of balance. I like to talk about the basics. And again, at Kook, we talk a lot about this because we're a very, very diverse service and see a lot of patients from all over the world. And not everyone is like, oh, the DSM-5. I know that like the back of my hand, and schizophrenia versus schizoaffective versus bipolar. There's really some delineations we need to talk about. Like nobody really gets down to brass tacks about that at Kook, because it's more about who is the human that we're working with and what do they have going on in their lives that's important that we can assist them with. So remember the basics. We are all human, and the people that we're working with are all human beings. So how can we be more human with them? It's something in some of the training that we do. We work with a lot of students, and it's so funny when students for the first time, so advanced practice nursing students that I work with, get into the room with the patient who happens to have a diagnosed mental illness. Sometimes they forget that they're a human being, and they start getting really clinical and like not remembering how to relate to people. My guess is that you guys don't have that problem because you're not clinical providers. And so you're always being human, but I think some of you have probably had experiences watching mental health practitioners forget how to be human. So they're talking to your patient or your client or whoever you're working with or your family member like they just stepped off of planet Mars and they're dealing with a Martian that they've encountered. Like, there's just really funny interactions that happen sometimes when people get nervous that somebody has a mental illness, right? So people with mental illness are human beings just like us, and figuring out how to speak about it, just really keep it in human terms. The other thing that I talk about a lot is that everyone at some point was this age or a child, and a lot of things that come up when people are out of balance feel like some of the things that maybe came up growing up or in their life experience. So like once we've lived life, a lot of what we've lived in life affects us and our balance and our ability to kind of keep things on our fingertips with our leg up in the air like that yogi guy versus tumbling and falling on our face. So who knows this chart? Who knows Maslow? Most people that have taken some psychology course at some point probably have seen this. I talk about this a lot because a lot of our clients that come who are refugees or immigrants who have fled some sort of awful thing in their home country, like really need these two things taken care of. So the basic needs that we need as human beings are to breathe, to eat, to have enough hydration and water to continue living, to procreate and have sex, to get sleep, to keep our bodies in balance, and to be able to poop and pee, right? Like those are, if we don't have those, we're really in trouble. And I like this on a spectrum when you're thinking about mental illness and mental health and the comparison, because I think when we're in good mental health status, we can kind of start talking about these things: morality, creativity, expansive. What do we want to do? What do we feel? What do we see about the world? Like, that's when we're like getting up here, right? When we're out of balance and feeling really stressed and ill, like I go back to here. Like, what do you need to feel safe? What do you need to feel like your needs are being met? How can you remember to eat? How can you remember to sleep? How can you remember to hydrate? We talk about hydration all the time. When people are stressed, anxious, depressed, have severe mental illness, oftentimes the first thing they do is not drink water. And then they get dehydrated, and that makes everything worse. So sometimes just simply, if you're sitting with clients, just being like, why don't we have a glass of water first and then keep talking? Might actually help kind of their brain and their body feel better so that they can think more clearly and be able to talk. Also have a snack. This is true for all of us, right? Making a major decision, walking into IKEA, having to face any kind of commerce, buying a home. Like, first things first, let's like take a deep breath, have a snack, drink a glass of water, and then make the decision. It's like a proven, funny social psychology thing. People with fuller bladders make better decisions. So again, when things get out of balance, it's because basic needs aren't being met and people are feeling unsafe. So that can be within their own mind. So their minds are playing tricks on them because they have a serious mental illness like schizophrenia or bipolar or depression, or they're using substances, and the mind themselves tricks them into thinking things that aren't real or based in reality. Other times it's external forces. So is your neighborhood unsafe? Did your cousin get shot? Did your parents, die when you were in Somalia and you watched your sister get raped? So like, what are the things that keep coming up for people that throw off the balance? This is directly cut and pasted, snipped and pasted from the NAMI website. How many people go to NAMI all the time? Write this down and have it as, one of your favorite bookmarks. Just did the NAMI walk on Saturday. It was great. Tons of people came out for it. It's the National Alliance for Mental Illness. Is that right? National Association or Alliance? Alliance, I think. There's local chapters, there's county chapters, there's state chapters, there's national chapters. It's a huge advocacy organization. And because I have 20 minutes, I'm not going to talk about all of these major mental illnesses. But if you click on these, it opens up to really beautiful descriptions. I will pull this up with patients and click on what we're talking about them having and just have them read it with me sometimes. Like, does this sound like you? Yeah, it kind of does. So that's what we're talking about. You have borderline personality disorder, and that's really hard. So, what do we want to work on there? It's not too clinical, so that I think folks that don't have a strong mental health background or have never even heard of mental illness can digest it. It's all in English, so if you have clients that don't speak English, you'll need to do some adapting and translating and interpreting for them for what it means, but I think it's the best site to go to for straightforward information. And then beyond it, they've got all kinds of connections to other resources, and you can call their hotline. It's a great source of contact for anything that you need. So just like we're all human beings, and everybody we interact with that's a human being is also a human being, including people with mental illness, everyone has human concerns, right? So you probably got here today, it's lunchtime, you're kind of fried, it's the middle of your day, you're just rushing here. Maybe you were hungry. Maybe you didn't sleep enough last night. Maybe your mom's having a hard time and you talked to her on the way here, and your uncle's has cancer, and your house needs a new roof because a tree fell on it, and your finances are mostly in order, but you're thinking about that retirement plan, and your cousin who has an uncle with cancer is really stressed and has been drinking alcohol too much, and the family's trying to figure out what to do about it, right? So who knows? Every family, every human has things going on with these things. Again, to do kind of the mental health, like we all have mental health, and it involves sort of these basic core components. These are things that often lead to the illness piece. So they're both symptoms that you can help people identify in themselves, but they're also things that suggest that maybe there is more of an illness going on. And if you're working in the community with folks that don't have a lot of resources or have a lot of context to be able to say, like, I think I feel depressed, or, I was reading about hypomania and I think that's what I have. Like, most people, that are people with PhDs sometimes don't even know how to talk about how they feel. So expecting people that we work with to know how to identify their illness, it's a pretty high expectation for a lot of people. So helping people kind of look at how their appetite is. Like, are you eating more or less than usual? Like, do you feel like eating? Kinda. I'll have a sandwich maybe at the end of the day because I don't feel like eating all day. okay, well, how can we make it so that you at least have a piece of toast before you leave the house in the morning? Or carry a bottle of water and like a snack pack with you, or know where the local shelters are that you could stop in when you do get hungry to get a free meal. So all of those things are really practical, and everybody struggles with it. Oh, I forgot to eat today, I was so busy. Or, oh, I can't believe all I had was a granola bar this morning and I was rushing, so my nice friend gave me a half a peanut butter sandwich on my way here. So talk about eating. It's also a really nice way to be human, and everybody likes to talk about food, right? It's a pretty common cultural interaction, like bringing food to someone's home or coming into their home. They usually will bring out food. Like, that's just kind of a pretty well accepted across the board cultural norm that we get together and we break bread and we have something to drink, and that's how we interact with other human beings. So it's a really easy entrance point to talk about how people are feeling, to talk about how their bodies are doing in terms of eating, being able to get things done. Like, you know, are you remembering to take out the trash, or do you sometimes notice that it starts to smell before you take it out? Have your neighbors complained at all that you kind of leave bottles around, and maybe you could pick those up? You know, little clues that people aren't functioning very well are really, you can ask really laid back, non-intrusive questions to see how people are doing, just like you would a friend or a neighbor. Sleeping too much or too little. So when people oversleep, that's a problem. When people undersleep, that's a problem. Common sense, right? Oftentimes, and I kind of ran this list because at Kook we have shared offices, so there's primary care, family medicine, medical pediatric residents and preceptors, and OBGYNs or OB midwives, and pediatric specialists that office with me. And so they come back and they're like, oh, you know, like these people have, this person I'm seeing right now, you know, like her friend just died and she's living in an unstable environment. Her mom's dying of breast cancer. She just keeps coming in with these body aches and these headaches, and I keep giving her Neurontin, and then I give more Neurontin, and then we've tried Tylenol and ibuprofen, and, you know, like, when people are stressed, their bodies usually feel it first if they're not super good at identifying what's going on in their mind and their feelings. So I'll talk about this later with resources, but oftentimes primary care settings are the first point of contact for people to come in and talk about their depression, their anxiety, their bipolar, their substance use. And it often gets missed as physical symptoms. And it's a really good clue for you folks who are buzzing around in the community or just an advocate in your own cultural community to recognize that. Like when somebody talks a lot about body aches, chills, my neck hurts, I just can't get this knot out of my back, I didn't sleep well again last night because my head hurts so bad, you know, sometimes I feel like I can't breathe or catch my breath. Those are just general signs that somebody's in distress and not feeling balanced, right? I haven't been eating enough lately. I always feel like I'm gonna die. What do you mean you feel like you're gonna die? I can't breathe. Like sometimes I can't breathe. Maybe they have asthma. There's a really funny thing between asthma and anxiety. They feed off of each other. Maybe they don't have asthma and they just have a lot of anxiety. I don't know. But exploring that with people is important, and also being able to advocate for them within the medical system that tends to treat the medical illness before starting to talk about feelings and what's going on at home in the environment. Are you being abused? Are you safe? All those things. It's just a big bummer. So we treat, and then all of a sudden realize this person is homeless and, you know, prostituting and really, really sad. So what can we do about that? Finances tend to be a big point of discord for people. Constant stress and concern. So trying to figure out how to assist people, and I would network in this room because my guess is a lot of you could help each other with resources. Finances, housing, that basic kind of bottom needs area of Maslow's hierarchy is probably the most important and the most basic for why people become mentally unhealthy or ill. So what do we do? Who are we? We are human beings. So interact like you're a human. form a relationship, which most of you probably already have with the people you're working with or are on the way to forming. So if I walk up to you and I'm like, ooh, you seem bad today, and I just met you, what are you gonna do? Be like, thanks, lady, get out of my face. Like, I don't know you, don't tell me how I feel. I don't want to talk to you about my bad day. Natural. No one wants to be told things about how they feel by somebody that they don't know at all. So forming a relationship is really key to being able to get anywhere with somebody who may be struggling. We talk about this a lot because we're all helper people and we want to really do good. So meeting people where they are at in that moment. Like maybe the next day they can talk about coming to Kook, about their mental illness and their problems at home and their resource needs, but for today they just want to cry and then they want to eat a sandwich and drink water with you. So do that day, and then the next day say like, you know, it seems like yesterday was a tough day. What can we do next? And maybe you eat sandwiches and drink water for a lot of days, and then eventually they can talk about how they feel, and then eventually you can assist them to resources, and sometimes that takes years, and that's okay too, as long as they have a person supporting them that understands and can sit with them in that terrible, hard stuff. And again, talk about the human concerns. So if you're getting nowhere with like, do you feel depressed? Do you feel anxious? Like, people don't always know what that means. So being able to talk about what are you eating? How are you sleeping? What is home life like? How are your relationships? How's your daughter doing? Sorry about your dog. Are you doing okay? Like, kind of those, again, human concerns and human relationships will help you get people to the point that they can hear you on how they're feeling and what they need. And also, so my resource suggestions for you, there's so many out there and there's so many great ways to enter. And my understanding is this group comes from across sort of greater Minnesota to these trainings. I can't speak to your communities and what they have to offer, but NAMI has a ton of resources. Your county, like every county has to have a county mental health something, some sort of provision of some sort of service through that county. Talk to them. If they don't have it, work with them to figure out how to get it for you and your clients. They can work with larger counties. They can network with other agencies. And then also look for primary care centers and community health centers. Federally qualified health centers like Kook offer a lot of resources that other health clinics can't necessarily offer in terms of federal, state, county dollars that are there to help the poorest of the poor and the people that have the least. So local community health centers can be a great resource. It's a plug for Kook, but also a plug for all community health centers. And in general, primary care centers are an entrance point for a lot of different types of care. I wanted to do this just because I think it's the most confusing thing. Everybody thinks about mental illness and they think you should go see a shrink. Go find a doctor who can prescribe you medication, right? It's a very small, so psychiatric providers down here, psychiatrists, MDs, there's never enough. They're specialty care, they're expensive, and they're few and far between. We have 3 part-timers at Kook that are passionate about our mission and are with us, but that's pretty rare within a community health center to have that much actual MD level psychiatrist support. You know, they are meant to be doing different things than community psychiatry often. So they're the folks speaking at the conference I'm at right now, doing the research and the academia and all that stuff, or in private practice, making a lot of money and interested in other things than community health centers. That's not a slam on psychiatrists, it's just kind of the truth of what we all know. Psychiatry providers, however, like myself and other folks that are NPs, CNSs, gosh, I forgot to put, PAs also can prescribe, but there's not a lot of them because their training is not necessarily specialty. But those types of practitioners are out there and a little bit more common, I would say, than MD psychiatrists. But the bulk of your prescribers that are going to be prescribing meds are in this camp, right? So most people get Zoloft, Paxil, whatever, Prozac from their primary care physician or their family physician or their pediatrician if you're under 18 or you're, you know, that's the entrance point if medications are needed. Sleep problems. Just having a stressful time, can't sleep, I just need a little something to get me to sleep. Go to your primary care center, your community health center. They can help with that. Specialty services are oftentimes not necessary, and people wait months and months and months to get into them when a primary care practitioner or a family medicine doc or provider could have provided that service a lot sooner. Mental health practitioners and therapists. This is another like acronym, what is after their name, what's going on here. So social workers, and social workers in the room, if I did the I always get the LICSW, there's like a bunch of little things that you guys have that I get confused about, but so masters in social work and licensed social workers can do therapy and bill for it, right? So I would say the majority of therapists out there working in the community probably are social workers. Marriage and family therapists is another line of training. LMFT you'll see after names. And then psychologists are PsyDs or PhDs. So even among psychologists, there's no like certain little thing after their name. Most clients don't know what they have. I have that conversation all the time. Like, who are you seeing? Jenny. Well, what does Jenny do? She talks to me. What does Jenny talk to you about? How I feel. Where do you see Jenny? Well, it's this building with rooms in it. Like, I don't see a lot of people when I go there. There's just a door I go in. Okay. So, like, trying to figure out who, like, the license level of the person that they're actually talking to. Oftentimes, people think they're seeing a therapist, but they're working with a social worker in the community. And those people can be just as effective as therapists, if not more, because they're in the community connecting to resources, helping people with really practical and emotional needs. So it's important, though, for people to know, to do some health education around who they're seeing and what they're getting from them. And also make sure that they're not hopping around to a lot of different providers and getting a lot of different medications that may be conflicting or interacting in a counterintuitive way. So the take-home points, remember to be a human. We're all human, remember to be human. Meet people, where they're at. In that moment, in that day, whatever they need from you, be there with them. Talk about human concerns. You guys are amazing. And then primary care and community clinics are what? Yeah, your first entrance point to care often, depending on what community you work in. Big cities and medium-sized cities like Minneapolis and St. Paul have more than just primary care clinics or community health centers. Most places in like the outstate areas, primary care is where you're going to get your service. And then what's the kind of best website for education on mental illness? NAMI, go to NAMI. So we're going to keep talking about lots of other stuff that's practical and questions later.
Hi, my name is Mohammed, like I said before, and I'm a psych care manager at Cook. So today what I want to talk about is what is stress and anxiety, what causes stress and anxiety, and how to reduce it so one can have more productive life and live their life fully. So stress and anxiety can affect us in 3 levels. First level is the physical feelings and symptoms, which can include stomach aches, diarrhea, constipation, muscle tension, aches and pains, headaches, frequent urination, having to pee a lot, nausea, dizziness, chest pain, fast heartbeat, feeling out of breath, sweating, shaking. I think I lost it. Okay. Fatigue, feeling tired all the time. Second level is the emotional feelings and symptoms, which can include panic, nervousness around people and groups, difficulty concentrating, not being able to pay attention doing simple tasks, anger coming out of nowhere, having short-tempered.
You guys hear in the back? You want her to shout?
Restlessness, can't sit still or relax, and having racing thoughts and worrying. And the third category is behavioral changes and symptoms. Loss of sex drive, change in feelings around intimacy, eating a lot or eating little, sleeping too much or too little, and isolation from others or situations, using alcohol, cigarettes, and other drugs to relax, and finally developing nervous habits like biting your hand and fingernails or pacing. So let's talk about what causes stress. So stress comes and goes. The physical and emotional impact of stress or anxiety is worse during significant life changes, like moving, starting a new school or a job, illness, injury, or death to a family member or a friend, getting married, getting divorced, or having a baby. Okay? So now that we address some of the pillars of stress and anxiety, how can we reduce it? What techniques and skills can we learn to reduce those stressors in our lives? So the following skills and techniques that I will talk about along with treatment for anxiety seem to be helpful with my patients. First, we can start with eating healthy food, eliminating caffeine, alcohol consumption, getting enough sleep will impact a lot on reducing stress. Drinking a lot of water, like Elizabeth said, getting regular exercise. It could be as easy as taking a walk or being in nature, doing meditation, yoga, Tai Chi, or stretching if one is physically able, or just praying or having a quiet time to yourself. Scheduling time for hobbies, to do things that bring pleasure into your life. And also deep breathing exercises. When we are stressed, our breath is contracted. So taking a deep breath fully into our lungs and abdomen and releasing it can have a huge impact in our stress level. So if one is using these skills and techniques and their stress is not manageable, where can they go for help? So if one is having thoughts about hurting themselves or hurting others, or even killing themselves or killing others, get help immediately. Call 911 or call COPE. COPE, Community Outreach for Psychiatric Emergency, is available to anyone in Hennepin County. They are available 24/7. They can do over-the-phone assessment or come to your home and do a face-to-face assessment if needed. And then they can address the following step, whether it's hospitalization or whatnot. I offer the following resources to all my patients. It's very helpful, and it will be on the handouts, their contact information. Crisis Connections, they offer free telephone counseling, and they also are available 24/7. Second Walking Counseling Center, they offer free counseling Monday to Thursday from 6:30 to 8:30, and Monday, Wednesday, and Friday from 1 to 3. Front Door, as we service a diverse group of individuals and they need access to Hennepin County services where they can talk to a live social worker and address their needs, and also Office of Multicultural Services, so they can be connected to services like for immigrants and refugees. And finally, what I want to say is the key here, you don't have to go through a long dealing with stress and anxiety. Utilize the resources and people in your life, even with providers. If stress and anxiety are not managed on your own, get the help that you need. Thank you.
I do it in the office when people come in really dysregulated and they can't slow down because they're upset. Like, just take a minute with people and just have them, and if they're safe with you and they feel like they can't do it, sometimes you can tap on their knees or just tap their shoulders back and forth in kind of a slow rhythmic way, or squeeze hands back and forth. There's a whole line of therapy that does that. It just helps people get back into their bodies. Oftentimes when people are really stressed and really overwhelmed, they're like away. Like they don't even know they have a body anymore. They're so gone. So those are just a couple of things that...
So far the handouts that you've gotten, I saw people asking, was the Welcome to Kook, the services that we have, which have some emergency numbers on the back. And then the second handout was the how to manage stress and anxiety. Yep. Missy, how can you? I'm connected to a cord. All right. And then someone asked about a handout for the PowerPoint, and we don't have one. Just go to NAMI. So how many people have been exposed to motivational interviewing training? Raise your hand. So-ish, some. So obviously I'm going to go really quickly because we only have about 20 minutes left together today. The basics about yep. Yes. So this is just to give you a flavor of it, to see if you want to go to more. So when you use motivational interviewing is when a patient is working, I'm going to use patient and client interchangeably. When a patient is thinking about a behavior change, and one direction of the behavior change is absolutely in their best interest, and yet they have ambivalence about it. They're not quite sure if they're ready, interested, willing, motivated to do that. The goal of the work is to enhance and strengthen their intrinsic motivation for change. So we all have different reasons why we're going to change, right? And if you think about your own life, let's say when you lost weight, or you quit smoking, or you addressed a sleep problem that you had, or some sort of behavior change, what tipped the scale for you? Was it because your mama told you to, or your doctor told you to, or was it because something inside of you was just the right time, or you felt motivated or ready or skilled enough to make that change at that moment in time? So it's to enhance and strengthen the intrinsic motivation to change. So there's a key phrase: a patient's desire, ability, reason, or need for change. DARN is the acronym for it. Desire, ability, reason, or need. So we all have those reasons not to change. We have desires, abilities, reasons, and need not to change. That's called status quo or sustained talk. And then we have the desire, ability, reason, or need to change, which is change talk. Okay, it's forward moving change talk. So why this works is that in research it shows that the actual minutes that a patient spends talking, saying change talk, the more likely they are to actually change. Which means what? Who should be doing the talking during a visit? The client, the patient. And the more moments, the more minutes that you're allowing space for them to explore their desire, ability, reason, and need to change, the more likely they are to actually make that change. And sometimes, because we're helper fixer people, when we see this inkling of, ooh, they're going to make this change, we just jump to planning and, all right, what's the plan? Let's do it. When are you going to do this? How? When? And instead, we need to slow down and make space for people to really explore their confidence, readiness, and importance about why they're making that change, how ready they feel, what, if anything, could increase their readiness, things like that. So the role of the provider is to help develop that discrepancy, to pull apart the whys to do it and the whys not to do it, to roll with any resistance that they have about the change, to draw out the change talk and selectively reinforce it. So it's not to say that we're going to ignore their reasons not to change, but we're just going to pick and choose the reasons that they are going to change on this behavior change. So there's a metaphor about this as if you're walking through this huge field with your patient. And you're taking a walk, and while you're walking, you're having this chat about the behavior change they're going to make. And you're listening to them, and you're selectively pulling out those beautiful, those nuggets of change talk as if they're a wildflower, and you're just picking up this bouquet as you walk along. And then at the end, when they come to a stopping place where they've really said all they have to say on that piece, you then present that bouquet of change talk back to the patient. You just give it all back to them, all the desire, ability, reason, or need to change that they said to you. So our role is as a shepherd, a catalyst, or a guide. So it's a non-directive approach, but you're also not just like swaying in the wind with the patient. You're listening and you're selectively reinforcing that change talk. And it has to come from a spirit of acceptance, compassion, partnership, and collaboration. Because we all know you could say the same two things with a different tone of voice and it come off meaning something totally different. In general, in motivational interviewing, let's say we had a 10-minute session. 2 of those 10 minutes we would just spend in engagement. Just spending time with that patient. How are things going? What would you like to talk about first? Maybe it's your 5th visit with them. How are things going with your sleep, eating, your mood, your relationship, whatever it is that you're picking back up again. but an open-ended, welcoming, engagement style question. Because we all know when we see our clients or patients, right away, they've got all this stuff they need to get out, this pool full of noodles, right? And let them just dump it for those few minutes. And then you're going to spend 1 minute in focusing out of those 10 minutes. So out of all that, those pool full of noodles that you just poured on the table, what should we pick out and focus on today? What is the most important thing to talk about today? There's lots of ways to ask that question, right? But again, it's an open-ended question that helps the patient focus on how to have an effective visit that time. And we're thinking about in a primary care setting, we have 10 to 15 minutes with patients. And it's amazing how much you can get done in those time constraints. Then you're going to spend half of your time, 5 out of the 10 minutes, just eliciting their ideas. So again, why do we make these behavior changes? Think to yourself about some behavior change you've made. And did someone else give you an idea that worked, or was it your own idea? So that 5 out of the 10 minutes, 50% of the time, we're just asking them open-ended questions to elicit their ideas. What have you tried before? What ideas do you have this time? When you think about your life 1 year from now, what's it going to look like? How would you work backwards from there to get there? There's a billion open-ended questions that we could be asking. What impact would getting enough sleep have on your life? Those types of questions. And then, if they're ready, you would spend the last 2 minutes planning. So you would say, what, if anything, might you do this week to make a little bit of progress on that goal? So see the if any, might you, all that kind of disclaimer language, it lowers defenses, and it's another skill that's used in motivational interviewing. What might be your next step, if anything? See how you could say, no, I'm not ready, let's talk about it next time. And that would be an okay answer to that question, versus if I say, what are you going to do next week? Sounds really teachery, right? Okay, so that's the flow of a session. If there was 10 minutes in general, 2 minutes in engagement, 1 minute in focusing, 5 minutes in evoking, eliciting, or drawing out, and 2 minutes in planning if they're ready. And then there's lots of skills that you can use in motivational interviewing, like SMARTer goals. You've probably heard of the SMART goals. Specific, measurable, attainable, realistic, time-bound. The E is for something that they're enthusiastic about, and the R is for something that they feel reward for. So I'll even ask my patients, when you do this, expecting someone to succeed language, when you do this, how will you reward yourself? And again, don't give your ideas, elicit their ideas about how they're going to reward themselves. This is not to say that in motivational interviewing we aren't at times going to need to give clinical advice or information. But there's a way to do that that's in the spirit of motivational interviewing. So if you only remember one rule today for motivational interviewing, it's that there's no unsolicited advice. None. No unsolicited advice. And because we're fixers, just kind of check yourself this week and think, did I just offer up an idea without asking if that was okay? Did I just offer up an idea without first asking their ideas about this concept? So exhaust their ideas first, then ask permission if it's okay to give them an idea, and then ask them what they think about it. That's a tool called Illicit, Provide, Illicit. Can you pass this out, Christina? Has anyone heard of Illicit, Provide, Illicit as a tool? EPE for short? Well, good. Then I'm glad we're going to talk about this. So EPE. So the first E is the illicit. What do you already know about high blood pressure? Might be an opening question, right? What do you already know about high blood pressure? And they tell you, well, my grandma had it, and I think it makes you feel sick, and then it provides you this opportunity to reflect what they already know, the knowledge that they're already coming in with. And then some more open-ended questions. what do you want, what more do you want to know about blood pressure, if anything? They're like, well, I'm just wondering, what could I do in my life? Like, I don't really want to take medication. I just rather deal with it in my life. How could I do that? Would it be okay with you if I shared some behavior modifications that might decrease your blood pressure? What if I had just started with that? I see your blood pressure result, and the 3 things you need to do are this, that, and the other thing to lower that. It's just so, it's taking away their personal power, as opposed to drawing out what they think about it first, drawing out what they want to know, offering a little tidbit, and then the last one, the last illicit, is turning it right back to the patient. So out of all that we just talked about, what, if anything, was new to you? So again, this is what it would sound like in a different scenario. Tell me what you're thinking about for birth control options. So even though it's not a question, it's still open-ended in nature. Tell me what you're thinking about, whatever the topic is. May I offer some information from a clinical perspective? That's a great one if you're debunking any myths that the patient may carry around with them. Can I share some options that you might consider? Then you lay out the options. And then again, you turn it right back on. What are your thoughts on that? What stands out to you? Or how does this information fit in with your experience? So again, it's turning it right back to the patient. So that's a tool called EPE. The next one I'm going to talk about is identifying change talk. So change talk again is D for desire, A for ability, desirability, R for reason, N for need. Desirability, reason, and need. So it's how to draw out that change talk. Well, before you can draw it out, you have to hear it. So we talk about being able to tune your ears to listen to change talk. And again, another tidbit I hope that you walk away with today, that change talk normally sounds like complaining. So when we hear it as providers, we often are a little annoyed or, they're still talking about this. This is my 8th patient today. I'm kind of worn down by all this complaining. Okay, so tune your ear to listen to actually, whoa, that actually was a wildflower that I was supposed to pick up. That was change talk. That was awesome. It's just said with this negative tone maybe. So along this spectrum of change, so the stages of change are pre-contemplative. Never even considered this change. Quit smoking? No, thank you. That's where I'm at right now. I love smoking, right? I'm making up a story, but. And then contemplative stage. I'm thinking about quitting smoking sometime. I don't know, maybe. Right? That's where they're at. Versus preparatory. Starting to make plans about this. So they're like, yeah, I could just quit cold turkey, or maybe I'll use some sort of patch or gum, or I'm thinking about my options, right? And then there's an activation stage. So I'm setting a quit date. I'm got a prescription for the patch, whatever it is, right? There's action, activation stage. Something is happening towards that behavior change. And then the maintenance stage. What it's important to know about behavior change is that most of us spend all this time in contemplation and preparatory stage, right? I know I need to work out more. I should totally do that in the morning before my kid wakes up. Yeah, that's what I should do. Maybe next Monday. Next Monday is a good day. I'm going to call my friend and see if she wants to do it with me. But no, she's busy, so guess it will be next week, right? Oh, I heard there was this gym that I could go to and they have a discount program. I should start that, right? Like, don't we all do this in our heads? We talk about behavior change inside our heads, but when do we actually do it? It's like this spark, golden moment, and pazzow, now we're like doing this behavior change, okay? But before that, we need to recognize and honor the fact that people spend a ton of time in contemplative and preparatory stages of behavior change. So we're just going to honor that and sit with that. So this handout that I gave you shows kind of what the language would sound like when they're in the stages of change. This could be through one visit or 2 years. right? Depends on the person, depends on the complexity of the behavior change. And then the darn cats, the desirability, reason, and need to change. This is what it's going to sound like. I want to. I don't like. I wish. I'd really like to, but. Okay, that's all desire. Their desire to change. Ability. I probably could. I might be able to. Those are the sentence starters you're going to hear. Reason to change. If I do this, then something good is going to come their way. Need to change. I have to. I've got to. My doctor told me, right? And especially with the need to change, that's a good opportunity for you to help a patient change from an extrinsic motivation to an intrinsic motivation. So why do you think that your spouse and kids are so worked up about this? What are your thoughts on that? You know, why are they so worried about you right now? Oh, your doctor mentioned that? What do you make of that? Right? To help them explore other people's concerns and why it might matter to them. I could talk about this for another hour. I'm going to move on. Hopefully that gave you a taste for that. How am I doing? Okay. The last motivational interviewing tool that I'm going to give you is called decisional balance. And this is a tool to help explore that ambivalence about change. But sometimes we see that there's only two sides of the coin, why you would, why you wouldn't. There's actually four sides of the coin. And it's important which direction you explore those in. So you're going to start with, what are the benefits of continuing as you are? What are the benefits of keeping smoking? Okay. Then what are the cons of quitting smoking? So what are the cons of changing? Then you're going to explore, what are the cons of staying the same? So what health consequences might you face if you continued smoking as you are? And finally, the benefits of changing. Imagine you were a non-smoker. What might the benefits of that be for you? Again, are we talking about this person actually quitting smoking? No. We're just exploring their ambivalence, and people can talk about a behavior change a lot more than they can talk about their plan to do it. So that's what I'm saying. Spend tons of time just exploring the behavior change, not the actual plan to do it. The plan comes way later when they're ready. This tool is so confusing to me that I draw these 4 circles on my paper when I'm using it, and I write, plus status quo, minus change, plus, right? And I draw a simple little graph to keep me clear when I'm talking with somebody about it. If you do it in the wrong direction, you might actually worsen the situation, because what we're left with, another tool for motivational interviewing, is that you always you backload with change talk. So if somebody gives you these 2 reasons to do something, like let's say about sleep, what might be some reasons that people are want to sleep more, or it's important to sleep more? What might be a reason that they give you? More energy. Okay, what else? Feel healthy, okay? You don't want to deal for getting more sleep? Oh. Okay, so that's a different side of the coin. That's if the behavior changes in a positive, forward moving, it's for sure in their best interest. No, not if they're talking about sleeping 24 hours a day. Yeah, it is true. And then what are some reasons that somebody would say they can't get more sleep? Too much to do. You guys answered that one way easier. Okay. So when we would talk about that, we would start with the sustained talk, the status quo. You have so much on your plate. It is really hard to squeeze in those extra hours of sleep. And you know how much better you would feel if you were getting maybe 1 more hour each night. So I just laid them both on the plate. There's not a but or a yet in the middle. There's just an and. And I put the sustained talk first, and I end with the forward moving change talk. And research has shown that research has shown if you end with the change talk, that's what they're going to talk about. So and you just hand it back to them, then they're going to be like, yeah, I would feel a lot better. Had I done it the other way, they'd be like, yeah, my life is too busy to do that. Okay, so backload or end with change talk. Four minutes, sure. Okay, the last thing we're going to talk about is another tool. It's called SAFE-T. And this is available on the SAMHSA website, which is Substance Abuse and Mental Health Services. Where's my long one? Hey, Nasteha, I need your help for a second. Can you grab me that green folder? So SAFE-T stands for Suicide Assessment, thank you, 5-step evaluation and triage. So at our clinic, a lot of different staff people are going to encounter somebody who is having suicidal thoughts. And sometimes we think, suicidal thoughts, call 911, right? Yeah, sometimes you need to, but there's a lot of assessment before deciding what you should do, depending on the acuity of the situation, right? That might be someone's baseline, is that they have suicidal thoughts that come and go, but they have no intent, plan, or behavior to carry that out. Well, then we shouldn't call 911. We should spend some time exploring those thoughts and what they do to keep themselves safe, right? So the first step is to identify the risk factors. What are some risk factors for suicidality that you know of? What's that?
Access to weapons.
Access to anything to harm themselves, yep. What else? Substance abuse, sense of purposelessness, anxiety, feeling trapped. What else? Trauma.
Not having any hope.
Not having any hope, sense of hopelessness, yep. There's a ton, so I'll just read a few more. Uncontrolled anger, seeking revenge, recklessness, seeming to do things without thinking, significant mood change from their baseline, having no purpose, no sense of purpose or meaning, a change in their substance use, so like sharp increase in their substance use, current or past psychiatric disorders, triggering events, any precipitating event that might be an interpersonal trigger, anything dealing with humiliation or shame, despair or loss. So it could be a physical change, a financial change, or a personal change. Previous attempts or previous aborted attempts, a family history of suicide, a history of abuse, emotional, sexual, or physical abuse, comorbid conditions, especially if there's a new diagnosis or worsening symptoms. And there's a higher incidence of suicide in elders, young adults, unmarried, white, male, living alone people. So we just pay attention a little bit more when they fit into that category, or one of those categories. Access to firearms or any other way to harm themselves. The second is to identify the protective factors. Oh, and I should say, it says on the sheet, but note any that can be modified to reduce that risk. So some things, if you have 8 previous suicide attempts, not really anything we can do to change about that, right? But if there's something else, no sense of meaning, is that modifiable? Absolutely. And that would be a great role for a provider to play, is to explore that with them and help connect to the community or a faith-based institution or a support group or whatever it may be, or engaging in a hobby, whatever it is to build upon their sense of meaning. The second is to identify the protective factors. So what are some protective factors? What keep us from killing ourselves? Family. Faith is a huge one. It's Spirituality, faith is a huge one.
Group support, groups.
Support, social support, absolutely. Religion. Pets. Yep, huge one. People, pets, neighbors, family, friends, all of that. Then there's some softer ones, like looking forward to something, having a hope or a dream. And it doesn't have to be huge. It can be that they have a date in their calendar with a friend in 3 weeks. Just something that they're looking forward to. And then the other kind of softer one is any sense of responsibility. So it may be to their job or to their family or to their pet. They're the one that feeds their pet. So any kind of sense of responsibility. And then positive therapeutic relationships or connections to social supports. So another role that we can play is helping them explore their support network and build upon that as well. So where else could you find connections in the community? And again, we would note the ones that can be enhanced to increase their safety. The third step is you conduct the suicide inquiry. So you're looking at ideation, plan, behaviors, and intent. So ideation is, have you had thoughts of hurting yourself in the last 48 hours, in the last month? What was the worst ever thought that you had of harming yourself? How much, how long does it last? So frequency, duration, intensity. Then the next is the plan. When you think about killing yourself, what do you imagine? A lot of people don't know. It's just a thought, but they don't know. They have no plan for it. But if they do, helping to explore that so you know the acuity. How would you do it? When, where, in what ways? And have you taken any steps towards killing yourself? Especially if a person has rehearsed anything or done research about it, that raises the acuity level of suicidal ideation. And then behaviors, which is where we're talking about past attempts, aborted attempts, rehearsals. Do people know what I mean when I say rehearsals? Like tying a noose or thinking about taking too much medication or loading a gun, things like that. And then intent. And intent means the extent to which that your patient expects to carry out the plan and also expects the plan to be lethal. So talking about when you think about doing that behavior, what do you think the outcome will be? And if they say, I'll be hospitalized, that's one thing. Or if they say, I'll be dead, that's another thing. And that's really important to help them verbalize that about what do they think is going to be the outcome of this behavior. And obviously it's a lot more risky if they think that the outcome is that it's going to be lethal. And then what do you do with that? Then it's up to you and the organization that you work for and your clinical background, your licensure, about what you do with that information. So you determine a risk level, and at our clinic we use low, moderate, and high risk levels, and we have very clear guidelines about what to do in the different scenarios. So low is going to look like they have really strong protective factors. They have kids that depend on them and a dog that they love, and they're super religious, right? And modifiable risk factors. They've thought about killing themselves. They feel lonely and a sense of despair, but they're interested in being more connected to the community. They're interested in their life being better. Versus moderate is going to look like they have multiple risk factors and only a few protective factors. And high is going to look like the protective factors just aren't relevant. When you ask them about things, you're hearing stuff like, there's no reason to live. No, there's nobody that depends on me. That really sense of despair. And when there's an acute precipitating event that leads up to it. There's lots of considerations to think about in suicide risk assessment. Pay attention to cultural barriers and biases, the expectation of how much we can disclose from the different backgrounds that we come from. Are we thoroughly exploring those protective factors? Again, not just a checkable box that they talked about it, but what is that like for you, those protective factors? How do you get engaged in that activity? And a fluid understanding of risk. Their risk is going to change over time and minute to minute. Collecting information from collateral sources, so getting those ROIs in place and talking to the support people in their life, or talking to other workers that are around, so that you're all have a team-based approach and have a larger picture of information. And then lastly, document whatever you do. So in your documentation, you're going to put what risk factors and protective factors did they note, what risk level did you assign, and then what intervention did you provide. And again, that's going to vary on the organization that you work for. So there are circumstances in which we're going to consult with someone whether or not we call COPE, and situations we know, nope, don't talk to anyone, just call COPE. And then there's situations when we might call 911, and other ones where we know you don't need to talk to anyone, just automatically call 911. What questions do you have about that? Safety.
So can you talk about COPE? Is that an organization, or what does it stand for?
So COPE stands for Community Outreach for Psychiatric Emergencies, and it's on the back of one of your handouts, contact information for them. It's 24/7 in Hennepin County. They'll go to the patient. This is a number that I give to the patient, to the patient's family as well, so that they can call. There's also Children's Crisis Team, which is like COPE for kids. So a mental health emergency. And they go out to the patient at their home. If they're at the mall, they can go out there. They usually get there within a couple hours. So if we're talking about an imminent risk, you just need to call 911. But if we're talking about this is a person that really should be assessed today, then you're going to be utilizing COPE and Children's Crisis Team.